in which the glial cells play a vital role. Meta-inflammation is caused by lifestyles, the key driver being the modern westernized environment. Hence, chronic neuropathic or glyopathic pain is lifestyle related, leading to the conclusion that lifestyle changes need to be incorporated in any holistic paradigm for chronic pain management. So these are the numbers basically to see the association between chronic pains as well as the obesity. So both will have environmental etiologies. So if you take information to look into a bit of the pathology of that, you see acute inflammation is due to an acute insult, due to a microbial pathogen or something like that, get frames of inflammation, and immune defense will come into play and you get resolution. Whereas in environmental triggers, inducers basically, it causes more or less a burning charcoal-like inflammation. It's called chronic inflammation. This causes dysmetabolism and chronic cholestatic diseases. So lifestyle is a cause for this meta-inflammation. So when you take the effects of this meta-inflammation, the immune system is changed such a way. You get a lot of endo is affected. What is most commonly talked about is endothelial dysfunction causing atherosclerotic cardiovascular disease. But apart from that, lung disease, the brain disease, Alzheimer's disease, joint diseases, degenerative arthritis, the bowel, inflammatory bowel disease, and the chronic neuropathic pain, all these are due to this meta-inflammation due to lifestyle changes. So chronic pain is contributed by various stress factors. So you see them. So causes anxiety, causes sleeping problems, coping problems, increasing pain. And this vicious cycle, breaking this vicious cycle is our main aim actually. We probably can't cure all of them, but we can control these risk factors and control this chronic problem. So are we unknowingly contribute to persistence of pain? Of course, yes. There are so many actions we do every day. Inflammatory environment around us, relationships we have, inflammatory eating patterns, inflammatory activities. So we have to control all these things to get rid of actually these chronic pain scenarios. So the new paradigm of whatever the emerging paradigm is basically a more holistic paradigm where, like the individual or dualistic approach, we just treat the patients what their medical problem and the psychology, but the coming paradigm basically we are looking into more social and behavioral aspects of the patient. The patient is not just a recipient of the treatment, but will be a partner of this treatment. So this sort of thing can be done only through a national program. So one single person would not be able to do the whole thing. So what we need, the need of the day is actually a national level program under the NCD campaign. So this will save a lot of money, more than what is saved by basically screening, treating other NCDs, because numbers are staggering. So at the institutional levels, what we need is actually more or less a comprehensive pain program, which actually has to be centered around a clinician and a whatever psychologist. Importantly, this is very important. That is because we need a diagnosis to treat. We just treat pain, that's the symptom, and we'll mask something under that. So it will cause disasters in the end. So we need to come to a diagnosis and then treat. So the initial decision should be done, initial assessment should be done by a physician as well as psychologist, psychiatrist, and then it has to go through an interdisciplinary team which comes to one table, not multidisciplinary. Multidisciplinary, you can report to a neurologist, then report to someone else, rheumatologist, rehabilitation. Not like that, but on one table they have to decide with the patient what treatment should fit this patient, should be individually catered. So this is roughly what a comprehensive pain team is like. So this success of this CBP is widely studied and basically evaluated. The average return to work rate from 20 different clinical studies shows that on average 67% of CPP patients return to work compared to only 27% of non-CPP patients. So this is important, and see every hospital level actually possible, we can start a comprehensive pain program which will basically help patients a big way. So with that background in mind, basically with We will talk about a little bit of pain basics. Without that, I think we can't discuss management of pain. So, go to the definition of pain. This is what IASP has defined as pain: an unpleasant sensory as well as emotional experience associated with actual or even potential tissue damage, or described in terms of such damage or both. So this part is to basically cover the phantom pain. You know, if a patient with amputated limb complains, say lower limb is amputated, now he's complaining of pain coming from big toe. There is no tissue damage, tissue is already lost. But if he complains, so that will be described in terms of such damage. So this is a comprehensive definition for pain. It's also important to note that when patient complains of pain, he is in pain. Sometimes what happens